All right, everybody. Sorry for the change up this week. Honestly, it's a lot of funerals and things like that come up last minute that I have to take care of. So hopefully you're watching this and take some good notes. It's going to be a good. This is one of my favorite topics to talk about. And I apologize if you hear kids in the background, but I'm doing this from home. Anyway, so my favorite topics is respiratory and cardiac. Those are two of my favorite mechanisms to take care of. So we're going to be talking about respirations, breathing difficulty, respiratory conditions, things that you might see in the field, and the inhaler, which we talked about in pharmacology, and a nebulizer, which we talked about in pharmacology. So respirations is to move air. The respiratory system changes pressure within the chest cavity. So I always like to say the human body is a body, and it is also a machine. So it functions like a machine. The way you move air in and out with the respiratory system, it changes pressure in the chest cavity to raise it up, raise it down. Like I said, when you inhale, pressure changes, your diaphragm goes down, and your rib cage goes out, and it creates space. That is created by negative pressure, which is used to move air in, and positive pressure is used to move air out. So just remember, negative is inhalation, and positive is pushing air out, which is exhalation. These changes in pressure are generated by contractions and the relaxation of the respiratory system, and basically the muscles. So here's a good picture. There's your diaphragm, right? In the relaxed position. So when the contraction happens, the diaphragm goes down, and then you can see in the diagram there how it's kind of doing that, right? So this is where the diaphragm would typically be. It gets pushed down when the inspirations are taking place. Everything contracts. So there's your diaphragm when you're inspiration. Then when you're relaxed, and the positive pressure, so the negative pressure is what's changing the area of the chest, right? The space. So the diaphragm goes out, rib cage goes out. But then when you relax and the passive expiration begins, and the diaphragm goes back up. So it's just good to know, like, relaxed diaphragm's in normal position, which also is your relaxed state, but you're also basically exhaling. When you're contracting with the negative pressure, diaphragm goes down, chest cavity goes up. Okay? Makes sense? So, inspiration, the active process, uses muscle contractions to increase size of chest cavity. So we've already covered this pretty well, I think. Rib cage out, diaphragm down. The intercostal muscles in the diaphragm contract. Diaphragm lowers, ribs move upward. Air is pulled in. So when you inhale, you just got to remember you're pulling air in. And the pressure changes so the air can get plenty of space to come into the bronchioles, down to into the alveoli. Gas exchange takes place, then you exhale. Rib muscles, diaphragm relax. Everything just relaxes. It's the opposite. Expiration, you exhale, everything goes back to normal. Diaphragm's up, rib cage is in normal position. Breathing sufficient to support life. So that's what adequate breathing is. So basically, when you assess someone, everything is going to be, are they adequate breathing or not, right? So kind of like I said before, is the airway patent? Is it going to stay patent? Same thing with respirations. Is it adequate respirations or not? If someone is breathing 45 breaths a minute and it's shallow, that is not adequate respirations, right? So the signs you're going to see is general, normal mental status, moving air when breathing. So basically, the first thing you got to look at is mental status, ability to speak, relatively normal without having to catch breath. So are they are they communicating like someone you expect? They're mentally stable, AAO times 4, awake, alert, oriented times 4. And are they using good verbiage? Like, are they breathing between words? Are they having a hard time getting words out? They got to take a break mid-sentence. All that is stuff that you're evaluating. Normal color and oxygen saturation. So are they cyanotic or are they pink, warm, and dry? Typical determination, right, is 12 to 20 breaths a minute as an adult. You do have to know these for test purposes and for in your career. I hate it when EMTs don't know this stuff, and they don't really know what a normal vital sign is for a kid. So know the breaths and vital signs. 12 to 20 is for adults. 18 to 30 is the school age kids. And you go back to lifespan development where we talked about all this and review that chapter too if you need. Infants, so newborn babies are 30 to 60 breaths a minute, and it's normally regular. So they're breathing 36 breaths a minute, but it's also regular. Breath sounds normally present and equal. So if you got the different age brackets, right, and you're evaluating them for respiratory distress or difficulty breathing, allergies, whatever the case may be, your page for difficulty breathing, you got to know what the respiratory rate is. So also know that an adult can have a respiratory rate of 12 to 20 breaths a minute, but is it good volume? Is it good? Is there good? Basic tidal volume, good gas exchange, all that kind of stuff. So, makes sense? Text me with any questions. Breathing is not sufficient, so it's too fast or too slow. So the rate of normal range is 12 to 20 for adult. So if an adult is breathing at 8 breaths a minute, that is too slow. Okay, if adult is breathing at 30 breaths a minute, that's too fast. So knowing the range that they're supposed to be at, because basically someone smarter than us found out what the range was. So basically if an adult is breathing at 30 breaths a minute, probably not adequate enough to get good perfusion. Okay, just like a heart, in a sense of if your heart is too tachycardic, you're not going to get good volume because the preload of the heart's not able to get a good preload to push sufficient amount of blood through the body. So same thing, if someone's breathing too fast, tachypneic, they are not going to be able to get good perfusion. Signs that you're going to look for: low oxygen saturation despite supplemental oxygen. I get paged a lot to families where someone's COPD, they're on oxygen, but they're still getting low saturation. Agonal respirations are things you're going to look for. Basically what agonal breaths are is dead man's breathing. They're either have no pulse or they're getting ready not to have a pulse, but they're agonal breathing. They're taking their last breaths. That is really weird because they're mentally gone, but really what your body now is doing is working exactly like a machine. That's all it's doing. It's breathing like a fish, like just trying to grasp for the oxygen. And so they're trying to get perfusion. The body knows, the dubla oblongata knows your body needs more perfusion, so it's just trying to breathe. And we'll YouTube it in lab day and show you what that looks like, but basically it looks like a fish. Irregular rhythm, so Cheyenne strokes, like we talked about, brain trauma, you see irregular respirations, diminished or absent lung sounds. You're auscultating the chest cavity, listening to all lobes, and let's say you got absent lung sounds on the right but not on the left, so you possibly have a pneumothorax. Poor tidal volume. Remember, if someone's breathing the normal respiratory rate that they should, doesn't mean they're getting good tidal volume, right? So got to make sure they're getting good tidal volume. The structure of an infant and child's airway for pediatrics differs from that of adult. We talked about this, right? So I'm just breezing through some of this. Smaller airway, easily obstructed. Proportionally large tongues. Smaller, softer, more flexible trachea, so it moves more than adults. Less developed, less rigid cricoid cartilage. Cricoid. So that's criking someone is when you cut into the cricoid cartilage to obtain an airway in their trachea. Heavy dependence on diaphragm for respirations. So these are all things that you're going to see in a kid and a pediatric. And you got to remember their diaphragm. There's heavy dependence on that. So like for an adult, you can look at respiratory rate by looking at their chest. Just look at it, count it for 15 seconds, times that by 4. You got your minute volume, minute respiratory rate. So with the P's, though, you can look at their stomach because they're dependent on that diaphragm. Sorry, guys, I'm a little tired. It's been definitely a busy week already, and it's only Monday. But anyway, so pediatric note, signs of inadequate breathing in infants and children. You're going to look for nasal flaring, which I feel like we've talked about a lot of this stuff already, but good reminder. grunting, the is really, I mean, they sound, you all have seen kids that working at breathing. Seesaw breathing, chest up, chest down, stomach up. It trades places. So when the chest goes down, the stomach goes up. Stomach goes down, chest goes up. Because that diaphragm's working overtime to get that, to try to get good breathing. And as we said, retractions, right, over the clavicles in that area. Assisted ventilation with supplemental oxygen. So when you see a kid inadequately breathing, now thing you got to look at, very important to know. I greatly apologize, guys. What you really got to know with pediatrics is they're going to crash fast and hard. Adults, you can watch them decline. Yeah, you usually got time to get interventions in place. But with pediatrics, you don't have that. They could be statting just fine, and also boom, they're in cardiac arrest. But no pediatric goes in cardiac arrest without. It's usually respiratory related. Now, for adult, you can watch them decline because it's either COPD, asthma, COVID, croup. I mean, not croup, but anything, colds that lead to it. But when you see anything not in the normal range, 12 and 20, 30 to 60, whenever you see those respiratory rates not in normal range, you have to intervene. Or if you see good normal respiration rate, but they're not getting good tidal volume, you have to intervene, right? So one of the ways you do it for inadequate breathing is assisted ventilation with supplemental oxygen. Pocket face mask with supplemental oxygen. We don't use pocket face mask. I don't know why that's in here. That's a first responder deal for sure, but usually cops or firemen. But for us, it could be BVM with supplemental oxygen, not in a breather, supplemental oxygen, 2 rescuer bag valve mask with supplemental oxygen. So same as the top one, you're going to bag them, but you're going to use help to get that good seal around the face. If you ever have enough crew, 2-man BVMing is the way to go. 1 rescuer bag valve mask with supplemental oxygen, not as adequate because it is hard to get good seal. So adequate and inadequate. So we've already covered this. Chest rise and fall should be visible with each breath. So when you are assisting someone or assisting them, watch your chest rise. When you're bagging them, you want 10 to 12 breaths per minute for adults, then 12 and 20 breaths per minute for infants. So the fact of the matter is usually for adults, like 5 to 6 seconds. You squeeze the bag, 1, 2, 3, 4, 5, 6, squeeze. 1, 2, 3, 4, 5, 6, squeeze. And over time, I've bagged a lot of people, so over time you'll develop muscle memory to where you're not even counting. But 12, 20 breaths a minute for infants and children. Increasing pulse rate can indicate inadequate or artificial ventilation in adults. So there's a lot of ways to gauge yourself. 1, you're bagging, listen to long sounds, watch chest rise. But you always, while you're doing this, have them hooked up to your monitor with end-tidal and pulse ox, and you're watching their heart rate. So one way you can tell, like, man, if their heart rate has to rise, that's their body saying, we're not getting enough oxygen, let's speed up the heart so we can get good perfusion. So if they're going tachycardic, that usually means you're not getting good, adequate artificial ventilations. So watch those things. I mean, don't just bag someone. When I'm bagging somebody, my job is I'm constantly watching chest rise, I'm watching their skin color, and I'm watching the end tidal, and I'm watching their heart rate all at the same time. Decreasing pulse rate can indicate inadequate artificial ventilation as well in pediatrics, because like I said, their compensation is not the same as an adult. They're going to crash. If they're not getting good perfusion, they're just done. Heart's like, nope, I'm out. And the kid will crash quick. So breathing difficulty, patient's subjective perception, feeling of labored or difficult breathing, amount of distress felt may or may not reflect actual severity of condition. So a lot of things you gotta look at with difficulty breathing is patient's subjective So remember, what a patient says to you is subjective, yours is objective. Um, it is subjective that they're having trouble breathing when they say it. Your objective state is what do you see through your assessment. Um, so for a patient, I had one just 2 days ago. Difficulty breathing on oxygen, home oxygen, and they were hyperventilating themselves because they weren't having difficulty breathing. They were having a panic attack that they began hyperventilating. Okay, subjectively, they're saying, "I have trouble breathing. I can't breathe. Help me out. I can't breathe." Objectively, good pulse ox, good respiratory rate, good skin tone. They were not having trouble breathing. They were having a panic attack. So you treat the subjective because you got to take care of that patient, but you can do it in a way that I calmed her down. I got her in the back of the ambulance. I took her off oxygen and talked her off a ledge, really. Calm down, take deep breaths. You're hyperventilating yourself, breathe in your nose, out your mouth. And I talked her through it. In your nose, out your mouth. And I was able to slow that down. But just remember, subjective is what they're saying to you. Objective is what you find. Feeling of labor, difficulty breathing. All of us in here has probably had days where we had trouble breathing, and whether it's allergies. I remember people with COVID. People with COVID were pulse oxing fine. They had good skin color, but they felt like they were having trouble breathing. Can't explain all that necessarily, but just listen to your patient. Amount of distress felt may or may not reflect actual severity, like I said. So this guy here is tripoding. He's a little ash color. He's diaphoretic. Around the forehead, you can tell. So that would be a guy I'm like, yep, he needs some oxygen. He's in trouble. So we assessed him. Onset. When did the difficulty breathing begin? Okay, always get that. Don't forget this stuff. OPQRST. So going over their assessment, you see them tripoding. Okay, let's say you walk in that guy's house right now. You walk in, hey sir, I'm Scott with Cheyenne County Ambulance. What's going on today? I'm having trouble breathing. So then ask him right away, when did the difficulty breathing start? And then what were you doing when it started? Well, it started an hour ago. What were you doing? I was cutting grass. I was just cutting my lawn and I got breathless. Okay. Quality. Do you have a cough? Have you had a cough lately? Have you been sick recently? Are you bringing anything up with your cough? Is your cough productive? So if they are coughing, is it productive? Are you making progress? That kind of stuff. Do you have any pain or discomfort anywhere else in your body? Does it seem to spread to any other part of your body? So basically how I look at it is when I walk in, go back to it, we go to that guy's house. I'm like, hey, sir, I'm Scott with Cheyenne County Ambulance. What's going on today? I'm having trouble breathing. Okay, well, I'm sorry to hear that. We're starting our assessment. And this time my partner's getting the monitor set up, vital signs, blood pressure, all that stuff. So how long would this begin? An hour ago. Man, what were you doing an hour ago that caused this? And at this time, I'm probably listening to breath sounds. And then he's like, well, I was cutting grass, which could tell me it's an allergy. That kind of stuff. Man, an hour ago, okay, you were cutting the grass. I'm sorry to hear that. Do you have any pain anywhere else in your body? Because remember, you can't just rule out cardiac or anything like that. Does it hurt anywhere else? No, it's just the center of my chest. Just the center of my chest. Like I feel like I can't breathe. Right. So that's basically how I get that kind of stuff done quickly. But while I'm doing these questions, you got to remember blood pressure is being taken, pulse ox is being taken, pupils are being checked, skin color has already been looked at, breath sounds are being listened to. We're getting all the things done. Then also severity. On a scale of 1 to 10. How bad is your breathing? 10 being the worst thing you've ever had in your life. 1, not at all. I'm an 8. Okay? And so you got to listen to those things. And then time, how long have you had this feeling? So it started an hour ago, but how long have you had this feeling? So OPQRST, right? So those are the questions you have to ask, and it'll become natural to you. But you're not stopping your assessment to get these questions. With you guys as EMTs, is different. For me as a paramedic, when I go on a call, EMTs are doing the EMT stuff. I'm doing the history taking. I'm doing the diagnostic stuff. But that's usually what paramedics do. But as EMTs, one of you will be doing the interviewing, and one of you will be doing the vital signs. Work as a team. Observing, altered mental status. Usually anatomy, barrel chest. So like this guy here, going back again. I wouldn't say he has a barrel chest. He doesn't look like that to me. So I wouldn't even say he may have asthma, but he doesn't have COPD. Patient's position. That guy was tripoding and sitting with feet dangling, leaning forward. A lot of times, some of them will do that. I don't know what they mean by dangling per se, but unless they're sitting high up on something, I don't know. But you will be dangling, will be sitting tripoding, leaning forward. Your body goes into position of survival. That's really what's happening. Are they retracting? Are they using accessory muscles to be able to breathe? Is their nostrils flaring? Pursed lips, like they're working up for a kiss. So like somehow your body just knows that makes that like a kissing look. But really what that is your body trying to get carbon dioxide out. And so it's going to come. So it's trying to get all that carbon out by breathing through that way. Number of words patient can say without stopping. Pale, cyanotic, flushed skin, pedal edema. Always look for pedal edema. If they're having difficulty breathing, look at their legs. They got pedal edema or sacral edema. So basically, wherever the gravity's pulling fluid, are they retaining water? Oxygen saturation, SpO2 reading less than 95, not good. Percent of the pulse ox. So this guy is a barrel chest. So when you're assessing this guy, and I've seen him look just like this. This is a great picture. He's got barrel chest. He's skinny. You can see around the clavicles. He is definitely retracting right there. You can't interview this picture, but from what they're saying here is he has altered mental status, cyanosis around the nose and lips. You can see it in this picture on the lips. His flaring nostrils. So this is a great picture. What I like too is straining intercostal muscles. So you always look for retractions up here at the neck, but then you're also looking at the rib cage and the stomach. Are they using all these muscles to breathe? Oh, they got numbness and tingling in their hands. So anyway, good picture. It should be in your book. And he has tripod, right? So you see the tripod position. Noisy breathing. So is he wheezing? Especially note in your reporting that he has wheezes heard with a stethoscope, or can you hear it when you walk in a room? Gurgling, like they're drowning. Snoring, stridor, coughing. Lung sounds on both sides during inspiration and expiration, because again, they may have wheezing on expiration but not inspiration. Or they might have wheezing on inspiration but not expiration. Or they may have wheezing on both. So you got to know those things. You can see this guy's listening to the back lobes. You will listen to the 4 lobes in the front, 4 lobes in the back, and under the armpits to get a good sound. High-pitched sounds is wheezing. Crackles, fine crackling or bubbling sounds heard on inspiration. We'll listen to some of these on YouTube. Rhonchi, lower pitched sounds resembling snoring or rattling caused by secretions in large airways. Remember, rhonchi and the bronchi. So if you remember, trachea goes down, branches off, trachea goes down, branches off. You got branches there, and then you got all your other branches. Rhonchi is in these areas right here. Stridor, high-pitched, is the upper airway, so that's up, higher, up here. Sounds indicating partial obstruction of the trachea. Evaluating vital signs changes when may include increase or decreased pulse rate. Again, changes in breathing rate, changes in breathing rhythm. So remember, rate and rhythm, just like your heart. And then hypertension or hypotension. So blood pressure, hypertension, hypotension, rate that to rhythm. So breathing difficulty, assure adequate ventilations. If breathing is inadequate, begin artificial ventilations. So in your assessment, are they adequate? If not, add this, artificial ventilation. If breathing is adequate, use a non-rebreather mask at 15 liters per minute. So their pulse ox, let's say, is at 85, but they got adequate ventilation. They're getting good respiratory rate, good volume. You don't need to help them with artificial ventilations, but you need to add 15 liters of per minute of a non-rebreather mask. Otherwise, it's 6 liters per minute. Okay? Try to remember for test purposes, look in your book. Because I can't remember if it's 8 or 10. But if you need more than 8 liters a minute, I would go with non-rebreather. Anything below 8 liters a minute, you can go with nasal cannula. All right, so patient care. This is your gauge here. So this, you have to do this for test purposes, hook up all your oxygen. But this here slides onto this air tank right here, and then tighten it. 15 liters, non-rebreather, but you can spin that around for whatever you need. And then this is how much oxygen you have in your tank. 4,000, 3,000, 2,000. Breathing difficulty, place patient in a position of comfort. What works for them? If they're tripoding, you could transport them that way. Sit them straight up. Administer a prescribed inhaler if they have one. Like, if you're interviewing them and they have asthma, if you take an inhaler today, yeah, let's watch you take another one. Let's go do that and help take their prescribed inhaler. Or, again, this is National Registry, but according to us, we carry it. Administer continuous positive airway pressure if needed, CPAP. So if their airway is not patent, is not staying patent, you're not getting good volume, non-rebreather's not working, go with CPAP. Continuous positive airway pressure. So blowing oxygen or air continuously at low pressure into airway prevents alveoli from collapsing. So basically, you're blowing so much air in there, you're keeping that alveoli open and not letting it crash. And then also it helps move fluid from the wrong place to the right place, basically, as best as possible. If that alveoli's got fluid, not only will CPAP keep the alveoli open, but it'll also push out all the fluid and edema. Continuous positive airway pressure. So common uses is pulmonary edema, drowning, asthma, COPD, respiratory failure. Reasons not to use, so contradictions why you don't use CPAP. So common uses, though, is for this. I'm sorry, I breezed over this real quick. Pulmonary edema, so fluid in the lungs, fluid in the feet, fluid in the legs. Drowning victims, push that fluid out. Asthma, COPD, respiratory failure in general. So contradictions is severely altered mental status. You don't want to put a mask on them that's already going to cause anxiety if they're mentally altered, because they're probably going to fight you. Lack of normal spontaneous respiratory rate, so they can't breathe on their own. Basically, you're not giving them artificial ventilations. You're not breathing for them. But if they can't breathe on their own, and you do got to breathe for them, you're not using CPAP. Inability to sit up, because you want to sit up at 30 degrees at least or more. And then if they're already sorry guys, if they're already hypotensive and they're in shock, you don't give CPAP. Main thing is with hypotension is CPAP is going to dilate you, so it's going to lower your blood pressure. So you don't want to lower it anymore. If they're at 90 over 50, I would not consider CPAP for that unless they're critical. Okay, life over limb, but you're going to drop them by 10 in their systolic. So, considerations: nausea and vomiting. They're vomiting, so you can't keep that mask on there. They're going to vomit into it and kill themselves. So, chest trauma. In a car accident, they have major chest trauma, facial trauma. I'll add that to there. They're in shock, upper GI bleeding, or recent gastric surgery, because again, you're going to dilate everything. You're going to lower their blood pressure. You can also increase their bleeding. Conditions preventing good mask seal. So facial trauma, like I said. What you're going to see is hypotensive for their side effects. You can cause a pneumothorax. So if they already have a pneumothorax, obviously you're not going this route, but you may cause one. Increased risk of aspiration. You're pushing all that air in there. So if they're nauseous at all, again, you didn't ask them, are you nauseous? You could increase their aspirations. The other side of that too is I would recommend giving Zofran. Everybody gives CPAP too, even if they're not nauseous. Get ahead of it. And their eyes are drying, their corneas are drying. You want to really explain the procedure to the patient. Be nice to them, respectful to them. Explain to them what's going on. Start with low level and then increase. We'll go through that in class. Hello, sir. I'm going to put this on your face, and just describe to them what you're doing. Reassess patient's mental status, vital signs and dyspnea, level of frequency, constantly reassessing. If they're on CPAP, every 5 minutes would be a reassessment. Typically it's 15 to 30, right? or local calls, 15 to 5 minutes. 15 if they're not critical, 5 if they are. Transfers, we're good with 30 minutes reassessments, but with CPAP on board, every 5 minutes we're recheck it, see if anything's changed. If they deteriorate, remove CPAP and begin bagging them. Always have, like I said before, always have a backup plan to your backup plan. Okay? Always, always, always. Especially with airway. Cardiac, you're kind of limited in what we can do, but airway, we have many options. Nasal cannula, non-rebreather, CPAP, BVM, iGel, Compe tubes. So there's a guy, he's like, oh, didn't work. Let's take the CPAP off, and we're going to start bagging him. Right? And as we're bagging him, we're probably going to get him to the floor because he looks like he's ready for a cardiac arrest. All right? Let me look here real quick. Sorry, guys. Let me just check something. See how we're doing on time. I got a meeting coming up. Man, I got a long way to go. Okay. So, I apologize. Like I said, you can't always plan funerals. Obviously, it's not a scheduled event per se when someone passes away. So what I'm going to do is we're going to stop there with this lecture. You already took your test tonight. I got to do my meeting, and I'll finish this chapter after I'm done. So Wednesday, let's see, we can't do class on Wednesday, it looks like. Or we can, just Trent can't be there. So we'll look at the schedule a little bit. I'm sorry, we're gonna make this work. I'm making this work for you now. I'm working overtime to try to make sure you guys get through this. But we're going to stop this for now. We'll be in touch. Let's plan on class on Wednesday for now. And I'll have chapters uploaded with some instructions on which ones to go through. All right? I appreciate y'all and your patience. Thanks so much.